So now we have Professor Alberto Larghi, is the medical executive of the digestive endoscopy unit at the Fondazione Policlinico Universitario, Germany, IRRCS in Italy. So today he's going to show us a case of EUS. So hello, Alberto. This is Raymond from Hong Kong. Hi there. Can you hear us? Hello, Professor Larghi. Hello there. Hello, Professor Larghi. So we couldn't hear you. Can you hear us? Oh. Hi there. Oh, so can you unmute yourself? Because I think the program probably has muted your side. So.
Yeah, unmute from your side.
We got sound now. So, hello, hi, Professor Larghi.
Hello, can you hear me?
Yes, yes, great.
Okay, perfect.
Yes, Raymond from Hong Kong here.
Thank you. Welcome to Rome.
Hello,
so
hello.
We are here with the team. Can you hear me?
Yes, yes.
Okay, thanks for this kind of invitation. I'm really grateful to be part of this very important historical event. So today I will show you a procedure of conversion of patients with acute cholecystitis to internalization with LAMS. So the patient is 81. He has a lot of comorbidities. He has an MI, chronic heart failure, chronic renal failure. So arriving in the ER with fever, with acute cholecystitis, and the interventional radiologist put a cholecystostomy tube in the gallbladder. Subsequently, day after, they call us to evaluate for a conversion to external to internal drainage. So I saved some time because I saw that you were a little bit behind. So I'm already down. So in these patients, there's very little literature. There are two small papers, one from the United States and one from Japan, describing a total of 15 patients treated for conversion. But I think this is an important indication because not all the hospitals have, 5, 4, 6 endosonographers, interventional endosonographers who can cover 24/7, while interventional radiology usually they have this service.
Right.
So in this case, so when a patient is out for surgery, I try to drain the gallbladder from the duodenum so the bile can flow in the right direction. And there's no really data that in terms of surgery, this patient will never have a surgery, but there are no data that compare patients who underwent transgastric drainage or transduodenal in terms of subsequent complication after surgery.
Right.
So here is the gallbladder. Here is the tube. You can see. So we are in the bulb of the duodenum.
Okay.
So one thing that is important. So this was a acute cholecystitis due to stones.
Yes.
He has some stones. So in general, so you can see the stones.
Yes.
Here. So in general, when you have stones and you think to go back and do lithotripsy, you need to place at least a 15 millimeter diameter stent, because otherwise it's very difficult to get into the gallbladder and perform lithotripsy. However, this patient, I don't know if it's fit for all this maneuver, or if it just will get just his internalization and so on.
Okay.
So we have to decide if we need to put a 15 millimeter or a 10 millimeter stent. In this case, we will put an axial stent.
Okay.
So we need also to check for the length, depending on, okay, this is a very nice view.
Yes.
Keep it.
Are you planning for direct puncture?
Yes, I go direct puncture with no fluoroscopy. So we are in a fluoroscopy room, but I work without fluoroscopy. I work with the Fluoroless US. So
Okay.
I use the ultrasound to guide me in the procedure.
Okay.
So I think we can get the stent. You need to keep it. So the most important thing when you use a lens, especially the axial stent, which has a diameter of 10.5 French outside diameter,
Right.
is to keep the stent straight.
Yes.
The scope straight, and to remember to not lock your dials and to not touch at all the elevator, because if you touch the elevator, it is possible also that the stent, quando ti dico di tenerlo, tienilo, that the stent, adesso no, the stent, here, that the stent, sorry, 1 second, that the stent gets grabbed into the elevator, and then basically the stent is kept and comes out from out.
Yes.
You have to keep it, because otherwise, so you see that here the gallbladder is a little bit floppy.
Right.
We have data, our data that we combine with a group in Belgium, in Leuven, and it seems that in terms of outcomes, or in terms of outcomes, the transduodenal is better than the transgastric.
Right.
I don't know what is your experience.
Yes. So I think at Prince of Wales, after lens placement, sometimes we put in the double pigtail stent to prevent food material to get into the gallbladder. And also, there's always a plan to come back for some cholecystoscopy to see if we can take out some stones.
Okay, tienlo qua. Okay, this is a perfect position. No. We are a little bit unstable, so just give me the 15 by 10 Axios. I don't know. I don't put a double pigtail stent at the first procedure.
Okay.
I keep it. I bring back the patient in 2 weeks, and I do a cholecystostomy.
Okay.
And if you have food, you can clean it up.
Okay.
In the duodenum, if you are in the duodenum bulb or in the antrum, I think also that the double pigtail stents do not protect you from food entrance.
Okay.
So we need to have a very stable position.
Yes.
So I'm very helpful to Diego that is keeping the instrument.
Yes.
Sì, si mette.
Okay.
So we're using a bio-Herbie.
Okay.
Oops. It's a little bit unstable.
Yes.
If I'm not able, I will go back to the stomach, but I will try now to do another attempt from the duodenum. So this is perfect. No, on the other side. No, on the other side. Here. Here. No. You rotate against me.
It's okay.
No, no, no. You rotate against me.
Yes.
So I'll do the last attempt, otherwise I go to the stomach.
Okay.
Okay? It gets into the right position and then it disappears.
Okay.
So she doesn't want to be drained.
Okay.
Sometimes you need a lot of patience
Yes.
because I like, in these cases, to really put into the stomach. You see how many stones?
Yes.
In the duodenum.
Yes.
So I will do the last attempt, otherwise I go to the stomach.
Okay.
Actually, we also check, oh, look, we'll do this.
Right.
That I think is the safest one.
Yes.
Ok, devi tenerlo, Dio caro. Here is the gallbladder. Lascia adesso un attimo. Ok. It's very, I don't know. Oh, let's see. Adesso tienilo, Non funziona. Non funziona. So we have 1 second, one problem with the Herbie.
No problem. No problem. So, yeah, no rush, okay?
No, patient first.
Yes.
So do you have a good experience with the gallbladder drainage?
Well, I actually don't do gallbladder drainage, mostly performed by Professor Anthony Teo and Professor Shannon Shen.
Okay.
Yeah, for me, I do EOSBD and also pancreatic fluid collection drainage.
Okay.
Yes.
Yeah, we are actually designing a study randomized for these patients because there's a lot of long-term complications from the percutaneous tube.
Right.
And Anthony, we will send you the protocol after the festivity.
Okay.
Because I think it's a very important indication.
Right.
Because what I said, it's not easy to have a service that covers for night and 24 hours.
Right.
Because, in a group, there are never, 10 endosonographers.
Right.
Stai concentrato su qua. Ho capito. Cioè, non guardare quello che fa lei fa lei. Ok. Yes. Oh. Ma poi scatta? Ma poi scatta proprio la fotografia. Dai, guarda, guarda qua, non guardare là. Tu devi stare concentrato solo su questo. Appena ti sei girato, è andato via. Let's look from the stomach.
Okay.
From the stomach, you have to be careful about the antrum,
Yes.
not to be too close to the antrum.
Okay.
So, okay. So I'll try to bring it a little bit on the right side. No, dall'altra. Non mi devi fare resistenza. Mi fai resistenza. Okay. I don't know what's going on, but it doesn't stay in the position stable for more than 10 seconds.
Right.
Okay, do you see? I think there is a problem also with the frame. Is there any question?
Well, no. So I guess it highlights each case is different. So I mean, this is a
Yes.
real-world experience. So that's why it's good to see how we troubleshoot the situation here.
No, the problem is that is not instead of there's not a you can see a big gallbladder, but it's difficult to find a stable so that stays distended for and stable for 2 minutes in front of you.
Yes.
The lens placement doesn't take more than 1 minute, 2 minutes. So
Yes. Yeah, because in our center, I think we also sometimes had a difficult case like this, and then have to really try to stabilize the scope. But sometimes it's really difficult.
No, but Diego is trying to help me out in stabilizing the scope.
Yes.
But I don't know why it does. As soon as it's stable, he changed the. And usually, sometimes in this case, you have a small gallbladder with a very thickened wall. Actually, on the CT, it was described as a 1 centimeter thickened wall, but it's not at all 1 centimeter. So,
Right.
So this is okay. È un problema di quant'è? Okay. Ok, vediamo. You see that?
Yes. Yes.
It comes and goes.
Yes.
No, ma lo so, ma se ne va da sola. Secondo me c'è qualcosa anche nella immagine. Ma non c'è una cosa delle immagini? Un problema? Io sai che cosa? Ho paura che mentre la faccio questo si sposta. And you are also afraid that while you are doing the drainage,
Right.
the gallbladder moves.
Yes.
It's enormous, but it's very strange because I cannot keep it fixed for more than 2 seconds.
Right.
Quello così? Vai. Staccami anche quello giallo. Sì, sì, vai. Adesso da qua. So we are inside enough to open the flange.
Okay.
Then I bring it back
Yes.
until it changes the shape.
Okay.
So we do everything under US. So this is enough. Step 4, I release the intra-channel portion, and then by bringing back this one, I release also the. So can you give me the endoscopic view?
Okay.
So this is release all under US.
Great. So, wow, very nice
Sorry
demonstration.
sorry for the time, but
Yeah.
you know, I think it's the best thing is safety because you know, if you do a damage in an 81-year-old patient with a lot of comorbidity,
Yes.
it's kind of not a very nice things to do. So
Yes.
it took a while, but you know, once you have the good position, then the stent, the placement of the stent is very rapid, and you have right away good flow. So by tomorrow, the stent will be almost open completely, and then we will bring back the patient in a couple of weeks to do cystoscopy, and at that point we will use holmium laser lithotripsy to get rid of the stones. There is no really, you know, there is the Hong Kong protocol for follow-up, you know, published by Anthony. Anthony and colleagues clean the gallbladder in steps or until it's totally clean. At that point, they substitute the metal stents with plastic stents. In reality, there's no really a consensus about how to do it. In certain patients, maybe younger, even though they have comorbidity, I tend to remove the stents and close the gastric part of that remain open with clips or with the Ovesco over the scope clip.
Okay.
So there's no really, you know, study in the literature.
Right.
So everybody's doing a little bit what they feel like, but I think we need the studies to clarify also all these issues. Even though, you know, as proved by the study from Anthony, at the end, percutaneous versus US GBD do not change mortality. So these are patients that are very sick. So you resolve the acute case, the acute phase, but then there are patients who have a lot of comorbidities, and then they have a short lifespan.
Right. Okay. So thank you, Alberto. So
Thank
it's
you.
a nice demonstration. So thank you very much.